Dynamic retinoscopy measures the effectiveness of the accommodation rather than the refractive error. It tells us how well and how symmetrically can the patient accommodate in real-life situations. We all know that if there is a paper to read at a distance of 1 meter, we need to do accommodation of 1 diopter and convergence of 1 meter angle. If this paper is situated at 2 meters, then the accommodation needed is half and the convergence needed is half. While if the paper is at half a meter, then we need to do convergence of 2 meter angles and the accommodative demand is 2 diopters. Actually, the actual accommodative response is less than the accommodative demands. This can be in the range of 1/4 to 1 full diopter. This is known as the accommodative lag. This accommodative lag is due to chromatic aberrations and depth of focus. What is depth of focus? In this figure, you can see in this lower part the image in focus for the flowers, the animal, and the trees. So all this is in focus. In the middle picture here, only flowers and the animal are in focus, while in the top picture, only flowers are in focus and the remaining are out of focus. This can be achieved depending on the diameter of the pupil of the camera. When the diaphragm is narrow, you can have many things in focus. This is a long depth of focus, while when the diaphragm is opened and the pupil is wide, the depth of focus is limited. This is the same situation in the human eye. In this situation, the pupil is narrow, then all these 3 states of the animal are in focus. So the animal can move from this situation closer and closer and still in focus without changing the amount of accommodation. So this is the depth of field. If the pupil is dilated, then the depth of field will be limited to small area. This is at the level of the retina. In the first situation, when the depth of field was large, the depth of focus is also large. On the second situation, when the depth of field is limited, the depth of focus is also limited. As you notice here, when the pupil is narrow, rays coming from each spot of the object can be focused in the retina. If it's focused here, this is actual point focus, but if it's focused a little bit in front, it will be a circle, or if it's focused a little bit behind, it will be circled. So the circle of least confusion is large. You can have an extended part here. While if the pupil is dilated, this zone is limited. So the depth of field is limited and the depth of focus is limited. This is the first factor. Same is the case with the chromatic aberration. We all know that when white light gets into the eye, the short waves are refracted closer to the cornea and the myopic side, and the long waves are focused to the hypermetropic side, and the yellow is on the retina. So again, we have a circle of confusion for the different colors. So we have two factors that can help the eye to see things at different distances without changing accommodation. So this is the explanation of accommodation lag. This is the case of chromatic aberration. This is the situation of the retina. Yellow will be immediately on the retina. Blue will be on the myopic side, but on reaching the retina will be a circle of confusion. Red is already on the hypermetropic side, so in touching the retina, it's a circle of confusion. Dynamic retinoscopy, it tells us how well and how symmetrical can the patient accommodate in a real-life situation. It helps us diagnose and treat some of the accommodative and binocular dysfunctions. Different techniques can be done for the dynamic retinoscopy. I'm going to cover three of them. The knot method, this is the name of the person who invented this way, the cross-retinoscopy, and the monocular estimate method of dynamic retinoscopy. The examiner attracted the kids' attention to an accommodative target and evaluate the retinoscopic reflex in both eyes. So here we have the retinoscope and the target that the patient will read on the same location, and these are located at the working distance that we want to examine. We need target to stimulate accommodation, and the retinoscope and the target are located at the working distance of the patients. First, I'm going to start the knot method. As you see here, the target and the retinoscope are located at the working distance. The patient should use distance correction when there is error of refraction. Now we are expecting that rays coming from the patient, and as the patient is accommodating on this target, we are expecting to see the movement of red reflex as no movement. But in most of the cases, we see a with movement because of accommodative lag. So this with movement is because that the accommodation is not to the degree we are expected to be. So the far point is behind the observer and the retinoscope. If the observer moves backward to be in the far point of the patient, in this situation, the observer will see no movement of the red reflex. Or the other way around, if the target stimulating accommodation is pushed closer to the eye, the patient will do more accommodation and a neutral movement will be seen. To know the amount of accommodative lag, we can move a little bit behind, or we can push the reading target closer to the patient till the red reflex appears neutral. Then this distance is measured, and the two distances are converted into diopteric value to work out the amount of lag present. For example, if in the original situation, the distance between the patient and the doctor was 25 centimeters, so the distance here is 4 diopters. If moving back, say for 8 centimeters, now the distance is 33 centimeters, or it is 3 diopters. So the amount of change here is 1 diopter. In this example, originally the distance 25 centimeters, this is 4 diopter. If the reading target was close by 5 centimeters, this is 20 centimeters from the patient. So now this is 5 diopters. So here we have 4 diopters and this distance is 5 diopters. So we know that the amount of movement here is 1 diopter. So if this distance is half or up to 1 diopter, we know this is accommodative lag. But if this distance is more than that, then this person get incomplete or weak or insufficient accommodation. So this is the idea. We start by the retinoscope and the target on the same position. Then, if needed, we will shift away, or we can stay in position but get the target closer to the patient. Let's have this example. The examiner is at the working distance of the patient. We ask the patient to look at distant object. Now the examiner will see the red reflex is a with movement. Now we ask the patient to fix the target here. Then we are expecting to have a neutral position if there is no leg. If there is a small leg, then we have something still with. But suppose there is no leg, then it will be a neutral position. Then we ask the patient to look away again. Again, the red reflex will be with movement. Then the examiner will get closer and ask the patient to again fix this, and we stay in this close position long time. We are expecting that the red reflex will be no movement as long as the patient is accommodating. So let's have this example. The retinoscope is here as 25 centimeters and we are having a neutral movement. We will stay at the same location, but we are going to push the reading target closer. Now we're going to see the red reflex is against. More closer, the red reflex is against. More closer, the red reflex is against. In this situation, suppose this is the maximum the patient can do. If we get any further, the patient cannot do any more accommodation and we're going to shift the 4 point will be away. So we know exactly that the patient can increase his accommodation by 4 diopters when he is fixing a 25 centimeter target. This method provides rapid and accurate assessment of the accommodative ability of both eyes, as the examiner quickly switched back and forth between the eyes. The result of dynamic retinoscopy in normal situations, it can be rapid, complete, and steady in both eyes. When it's abnormal, we can have incomplete, sluggish, momentary accommodation only, accommodative lag, or asymmetry. What about the cross-retinoscopy? Here we have the target at the working distance. We ask the patient to accommodate on the target, both eyes. Any error is corrected on this situation, so the patient has to put on his distance glasses. So the expected movement of the red reflex should be no movement, but there is a with movement obtained because of the accommodation lag. This is in the range of 1/4 to 1 diopter. To cancel this accommodation lag, we start to put plus lens on each in front of each eye at the same time with a power of 1/4 or 1/2 up to 1 diopter to cancel the accommodation lag. Now we're going to have no movement. So I'm going to add 1/4 to 1 diopter in front of each eye to reach a neutral position. Now, if we start to add more convex lenses on each eye gradually, the patient will start to relax his accommodation. The more we add power, the more the relaxation of accommodation will be done. Till we reach to other point that the patient did a maximum relaxation. So in this case, our more addition will result that the far point will be here, and we are going to shift. Instead of seeing neutral position, no movement, we're going to see an against movement. So we know exactly how much accommodation can be relaxed at this situation. What about the monocular estimate method? The vertical streak is moved quickly across the horizontal meridia of one eye and then the other eye, and the motion of the reflex is observed. A measuring lens is briefly put in front of each eye at the spectacle level, and the magnitude of motion is estimated. Any difference in accommodative response between the two eyes is observed. So the three techniques, the knot method, the retinoscope is moved closer or further away until neutral motion is observed, while the fixation target is held at a constant near point. The cross-retinoscopy, the patient binocularly fixes the target while the examiner adds spherical lenses over the spherical correction until the neutrality can be observed. The monocular estimate method of dynamic retinoscopy consists of estimation of a monocular accommodative response in binocular conditions using a rapid interposition of spherical lenses. Let's give you two examples of the use of this dynamic retinoscopy. In this first example, a 16-month-old girl has 1.75 diopter of anisometropia. Is she beginning to develop amblyopia? We know that accommodative error is generally symmetrical, but we don't know if this patient is always accommodating with the less hyperopic eye, then probably there is amblyopia or the amblyopia is at high risk to occur. While if accommodating with more hyperopic eye all the time, then the risk of amblyopia is low. On doing retinoscopy, with particular attention paid to the more hyperopic eye, if it is consistently hypoaccommodating, then an isometropic correction is required to restore symmetry and should be prescribed. While if the eye shows evidence of full accommodation to near stimulus when viewing under binocular condition, observation alone is acceptable. A second example, a 6-year-old girl complains of tiring after reading for few minutes despite near acuity of J1 plus in each eye and normal convergence and cycloplegic refraction of 1.50 both eyes. Are her complaint fictitious? Measurement of a normal near acuity alone in this patient does not fully characterize her accommodative state. Dynamic retinoscopy might reveal rapid, complete, but unsteady or discontinuous accommodation in the low hyperopic eye, confirming the diagnosis of accommodation insufficiency and reinforcing the decision of treating his with glasses. If you check this article, other examples are shown there. At the end, thank you for your attention.